staff are in listen-only mode.
Hello.
Testing 1, 2, 3. Testing 1, 2, 3. Hello, Ahmed. Good morning.
Good morning.
Fantastic. I'm glad that you came over. We have these wonderful turnouts. We're lucky if we get 1 or 2 people. Hopefully, Boeing will be here. Dr. Oldtree may be here.
Brett, you're unmuted, Brett. You're unmuted. Hello.
Okay,
Ahmed.
hey, welcome everyone. Thanks for having me.
Good morning. Good morning, Calvin.
Morning.
Good morning, Cindy. Hello, Dr. Ping. Good morning, Nadine. Hello, Holly. I've sent your PIN number to you so you can enter the PIN number and use your phone. Holly, I've unmuted you now. Can you speak to me? Testing 1, 2, 3, 4. Testing 1, 2, 3, 4. Hello, Holly. Are you there?
Hello. How do I unmute? Let me figure out how to unmute.
Oh, you are unmuted now. I can hear you.
Yeah, I'm here.
Oh, good. And we're looking for Dr. Lenahan, correct?
Exactly. And Josh.
Yes. Are they tuning in now? They coming on?
They should be. I'm not in the same spot. I haven't seen them this morning.
Okay. Got it. All right. We'll just wait for them.
Yeah.
Hello, Nadine. You're self-muted. Nadine Henning. If you want to go ahead and mute, and then you can unmute when you want to speak, that will keep us from having any feedback. Oh, here comes Joshua.
Oh, right here.
Hello, Joshua. Good morning.
Good morning.
How are you this morning?
Good, thank you.
Joshua, are you going to be the presenter?
I will present the first case. I know Dan was I'm in a different spot than Dan was, so I don't know if he was loading up the PowerPoint, but if there's a way to give me control, I can load it up.
I'm going to give you control, and right now I'm going to change you to the presenter.
Okay, that's easy enough.
And you are now the presenter, okay? So go ahead and load up. And I can see you loading your PowerPoint now.
Do you see it now? Because I do not.
Let's see. Did you show your screen? I saw you loading, but I don't see anything else. I saw you loading. There it is. I can see it now.
Ben Hummel. Have you ever been Ben Hummel yet?
I don't think I have.
Hello, Marcelo. I just unmuted you.
Yeah. You've been on.
Hello, Marcelo Calvacanti. Good morning. Here comes Dan. Hi, Dan. I just unmuted you.
Hey, Eric.
Hello, Dan.
How are you?
Never had any discipline presentation. It's just like what I do. Really phenomenal.
Bom dia.
Hello,
Eric,
Dan.
can
I
you
hear
hear me?
you well. Hello, Sebastian. How are you today?
Nice to meet you.
Oh, good to talk to you. There's some noise in the background, so if everyone could self-mute, otherwise I'll have to try to find you and mute you. You hear a lot of background noise. I'm going to take one at a time and mute them till I find it.
I don't think it's me, Eric.
I don't think it's you either. So let's try. Take one at a time. Calvert, I'm muting you. Not Calvert. Not Cynthia.
Somebody is talking fast.
Still working my way down. It's Marcelo. Marcelo Cavalcante has been muted by the organizer because of feedback.
Okay.
Thank you, Marcelo. Okay, Dan, it looks like you're up, and we can wait a few more minutes if you want to.
No, I think we got a lot of stuff. So if Josh, if you have control, is he on?
Josh has control.
I'm on.
Yeah, I got your slides, but it looks like you have yours up, so that's fine.
Okay, sounds good.
Looks like Joe Carver is coming on now. So let's just wait a few seconds, as we're getting a few people coming on. Hello, Joe Carver. How are you today?
Good morning, Eric. How are you?
It's good. It's good to talk to you. We have,
Morning, Joe.
I'd like to introduce our executive director who's on today, Brett Harrison. Hello, Brett.
Excellent. Eric, Brett,
Morning, Brett.
what part of the country is Brett in?
Brett,
Hey Dan, hey everyone. I'm here in Irvine, California.
So it's like 4 in the morning or 5 in the morning?
About 6 in the morning.
Yeah. You had to get up early.
Yeah, sun's rising. It's going to be another sunny one.
Perfect.
Okay,
All right, Josh, I guess you can go ahead. Yeah.
we can go ahead. We are recording for quality purposes and actually to post it. And so eventually it'll be posted at our website. Right now it's being posted at Eric E. Harrison, MD, Vimeo. Eric E. Harrison, MD, Vimeo. So Josh, go ahead and introduce yourself and get started.
Yeah, good morning. My name's Josh Mitchell. For those that you don't know me, I'm a new faculty at WashU in cardio-oncology. We have a couple interesting cases to present today. I'll present the first one, and as time allows, Dan will present the second one. So we were called for a possible cardiac etiology for a patient's worsening shortness of breath. So she's a 39-year-old lady. She was unfortunately diagnosed with poorly differentiated pericardial mesothelioma about 7 months ago. And I'll show you an echo in a second. It was had significant involvement around the heart and was affecting the heart. And she received radiation therapy for it. To back up, though, just so you can see kind of her history as we approach her shortness of breath now, I wanted to show you her echocardiogram from diagnosis, although we just have a still image right now. And so you can see here on the image, I guess you cannot see my pointer, it doesn't look like, but I did annotate that you see a mass anteriorly. You see the RV, LV, the heart's relatively small in size. The mass completely wrapped around where the aorta is as well, and is exhibiting mass effect on the RV. You can also see somewhat of a pericardial effusion behind the LV as well.
So Josh, you can see your pointer.
Yeah, but you could see the names on it, right?
No.
You can't see the word mass?
Oh, yeah. Sorry.
Okay, all right, good. So she, in brief, she underwent 30 grays of mediastinal radiation. Obviously, the heart was in the affected zone because it was right there. She'd also been on cisplatin, etoposide, and pemetrexed therapy. But everything had been on hold. Most recently, she was on maintenance pemetrexed because of ongoing issues with dyspnea, tachycardia, chest pain, for which she's been being treated for radiation pneumonitis. So she's had 3 admissions now over the last 3 months. She initially received treatment for aspiration pneumonia at an outside hospital, and then now she's been on high-dose steroids for radiation pneumonitis. And unfortunately, every time they are tapered, it gets worse. 1 month ago, she was seen by pulmonary. Her daughter had recently been diagnosed with RSV, and so she was tested for RSV and was positive. And so they felt that maybe RSV was contributing on this particular hospitalization, and she was given ribavirin as well as steroids. She was treated initially with high-dose Solu-Medrol 60 milligrams BID, and she did in fact improve. She was doing well off oxygen for several weeks, and then as the steroids were being tapered, she started having worsening dyspnea exertion. She felt like her heart was going fast. She had increased oxygen requirement. So this admission, she reports that she's had increased dyspnea over the past 3 to 5 days. She can't walk 10 steps without stopping and taking a break, so she can't even get to the bathroom on her own. She's been oxygen dependent now. She's on 3 liters at rest. She needs 6 liters with activity. And she also complains of some chest pain with exertion and is noted to go get tachycardic in the 140s pretty easily with just any minimal exertion. Also note, she did have some facial swelling, but it really looks like moon facies associated with 3 months of steroids. She has a vague feeling of upper body swelling, although there was nothing to substantiate that in an exam. And on a review system, she also has some occasional headaches. And I put those here, although it's a duplicate. So our oncology history in slightly more detail. 7 months ago, she was diagnosed. She'd actually initially been found to have a pericardial effusion a few months prior to that. Even went underwent a pericardial window 1 month prior to diagnosis without receiving her true diagnosis. And then when she had ongoing issues, this was all outside hospital, had a CT scan, which finally showed the mass, and then she underwent pericardiocentesis with pathology consistent with pericardiac mesothelioma. So she underwent 4 days of palliative radiation at the outside hospital, then was started on cycle 1 cisplatin etoposide. I have not shown, I moved the order, so the echo I'll show in a second is from right after all of this. And then after that, completed 7 fractions total of radiation, and then was changed to cisplatin pemetrexed and eventually maintenance pemetrexed therapy. So on physical exam, she's afebrile. She actually looks comfortable lying in bed, although you do note that she's tachypnic. She is on oxygen. Her heart rate's fast on the monitor, and every time she walks, it goes up pretty quickly to 140s. And then she does not have any JVP on exam. Her heart, other than the tachycardia, is regular and no significant murmurs. She has no edema on exam, either upper or lower extremity. She does have some facial swelling that looks like moon facies. So for her labs, she's been noted to have a leukocytosis on steroids, of course. She has good renal function. Her liver enzymes are fine. Her cardiac markers are all within normal limits. Here's her EKG. She does have some right axis deviation. It's possible left atrial enlargement. And then she's obviously tachycardic and sinus. So during her evaluation, this hospitalization, she had a CT. You can see the remnants of the mass. The oncologist is actually fairly happy with how it had responded to therapy, and so though it looks worse on this particular image, some of this is just necrosis or effects post-therapy. But there is some concern whether or not there's some SVC narrowing or not, and she'd had a catheter in place. But then she underwent echo, and again, I don't know. Obviously, it was played before, but it doesn't seem like it's playing now. Oh wait, there it goes. It's going a little bit slower, it seems, for you guys. But you can see that her overall EF is good. If you pay attention to the lateral side of the mitral annulus, and I know you can't see my pointer, there's some thickening that's felt to be tethered there as you look over all the images. And so overall, there is concern for pericardial constriction on the echo, which is not surprising given her significant radiation. She does have annulus reversus, which is where the lateral wall is tethered and the septal wall moves more than the lateral wall. It was mild. The septal wall was 7 and the lateral wall was 6, but it was there. And then she had some other concerns for constriction as well, including on the strain pattern. You can see that the lateral wall appears tethered, is not moving well, consistent with some constriction there. And then she has a finding, which is a late diastolic dip, which I pointed out there, a little bump on M-mode, and everyone's not used to M-mode necessarily, but that late septal diastolic dip is consistent with constriction. So the formal read on the echo is certainly concerning for constriction as well. So in this setting, we were called to see what we thought. She's responded to high-dose steroids, but every time it's tapered even to a relatively substantial dose of 40 milligrams daily, she gets worse. There's signs of pericardial constriction on the echo. Would it be reasonable to try, pericardial stripping, obviously a morbid procedure? And then there's some question of whether there's SVC narrowing or not. There was some question also of pulmonary vein obstruction, although that was more questionable as you look through all the CT images, and I didn't have a good one to show you, so I didn't show it to you. So with that, I just thought well, real quick. So the pulmonary SAR, again, agreed with radiation pneumonitis. I said to increase her steroids to 80 milligrams daily. She'd had some headache, sinus fullness, and so look for some possible sinus disease, and then she had immune facies secondary steroids. So that I thought I'd open it up to discussion, what people thought and what they would like to do for any evaluation or management.
See, Josh, go ahead, Dan. Go ahead, Dan.
Well, I was just going to ask, how did the oncologists, or what was their general feel for how she had responded to all the chemo and radiation that she had gotten?
So the oncology was overall actually happy generally with her response. She is high risk for disease. She has an overall poor prognosis, and I think that's probably what you're alluding to, Dan. Although right now they felt like her disease was stable. It was being complicated, any maintenance treatment, et cetera, was being complicated by her radiation pneumonitis that they were treating. They did not feel like there was, significant progression of her disease, or that things were more in a unstable situation with regard to underlying cancer.
I would comment. I don't know can you hear me? I'm not sure if it goes.
Yes, we can hear you.
You can? Good. Okay. Yeah, Ron Cron. So I would comment. I don't know this patient, but one thing that always interests me is the effect of sinus tachycardia in morbidity in these cancer patients. And a number of them, I've had one dramatic and some others, where they have an inappropriate sinus tachycardia. And here it's kind of interesting that she's got a mass right around the sinus node. And you wonder if that's playing a role. And amazingly, she's still in sinus rhythm. So this is some place where I would seriously consider treating her sinus tachycardia. That had been reviewed. Actually, Dan suggested it a long time ago. And it's been very successful. Otherwise, looking at the cardiac situation, her contractions are good. The only possible issue might be some subclavian stenosis, except that she's not having any edema, and her JVP doesn't seem elevated, so it doesn't seem like that's significant. So from a cardiac point of view, that would be the area that I would focus on.
So I'm wondering if she's maintaining her cardiac output with her heart rate because of stroke volume being limited by constriction. And so how much evidence do you have that there's constriction? I didn't see the coronaries on the study. I'm not sure if it was gated, but sometimes coronary motion can tell you about constriction too, because they're used as epicardial markers.
That's a good question, and I don't have information on that. I will say that her cardiac output was reduced, even though her EF was maintained. Her LVO TVTI was 12.
So you might get in trouble if you limit her heart rate, if that's basically making up for the lack of stroke volume with her current cardiac output and possibly quasi-constriction physiology. You probably had to give her some volume overload to really see the constriction if she has it.
I think you just have to be very careful and monitor her. I don't know that the effect would be that dramatic anyway, but there's no way of knowing which is the major factor. I mean, but the fact that she's got a normal rhythm at rest and then with exercises it seems inappropriately high. That doesn't seem to me like it would all be due to the constriction. But I mean, you'd have to be very careful with it.
So Corlinor may be a drug that could be chosen as a funny channel blocker to see if we could slow down her heart rate rather than a beta blocker. What do you think about that?
It's just what I said.
Yeah, I don't think given her tenuous pulmonary status and, you know, basically normal blood pressure that there is any way she could tolerate a beta blocker for sure. So, I mean, if you wanted to suppress the heart rate with ivabradine or Corlinor, that's certainly one possible approach.
So, it's Joe. I would probably do a right heart cath and see if what we're really doing.
Yeah, I think it's really hard to know what her pressures are.
Yeah, I think that's a great recommendation, Joe. Overall, our thoughts were a few. One was that, as has been mentioned, while she doesn't have elevated JVP, sometimes that can the constriction can still be more occult, and you can see the elevation after volume. Usually JVP is elevated in constriction. One case series or one report had 93% elevated JVP, but it certainly can happen without signs of volume overload. And often she was felt to be maybe even volume down whenever she had any evaluations done. So one question was, is the symptoms that she's having, which she was tachycardic at rest, but she was significantly tachycardic with any movement. Was it from that? Was this from SVC narrowing? Was that significant or not? That was unclear. And we had a multidisciplinary meeting with oncology. We also had CT surgery weigh in with regard to what they thought, even in the absence of a right heart cath, with what her options would be if she did have constriction. She certainly had definite signs of at least early constriction on her echocardiogram. In talking with everyone, she was feeling better on her high dose or steroids. So we put off, because again, she was stable, but she had a very poor prognosis from her disease. So we put off invasive procedures for now. So she was then seen in clinic, and symptoms were progressing. Now she complained even more of this feeling of upper extremity swelling. Headaches were worse, and she now had, and she continued to have the tachycardia and the chest pain. And so here again, the easiest thing to do with the morbidity of the pericardial stripping would be to possibly fix an SVC obstruction if that was cause of her symptoms. It's certainly rare to get it, but she would be at risk for it given her radiation field. So she was referred to a right heart cath and possible SVC dilation. And on right heart cath, her RA pressure was 11, and there was a 22 millimeter gradient across her SVC. And she underwent dilation with improvement here on the echo. And then to show you her CT scan, that again was the best image I could show you from before and then afterwards. And this made a significant improvement in her symptoms. And so although she did have those signs of constriction on her echo, this being a much more or less morbid procedure that she tolerated well, was able to help her with her symptoms and not put her at great risk. So go ahead, Dr. Kern.
Question on the echo: Did you were you able to image the inferior vena cava? I mean, that's a good way of looking at. I mean, you've got a separation between the SVC with the local disease, and then you've got the global issue with the pericarditis. But I wonder that the echo should be able to show you the IVC and give you some idea if there's dilatation there.
That's a great question, and even though that's very accurate, I don't remember. I haven't looked at it recently, but I know it wasn't dilated. I can't remember if it was intermediate or if it was flat and collapsible. But there's certainly every echo she's ever had questioned that she was volume down, because in general her IVC was flat and collapsible.
So and what did you say what the pressures were when they did the right heart cath?
Yeah, her
11.
right atrial pressure was 11, and her gradient across her SVC was 22.
So that means her venous pressure in her head was 33.
33.
A little high. A little high.
And so it may have just been a JVD.
So you're not going to see JVD when your pressure is 33, because you would have to have the patient stand up and look at their scalp veins to be able to see that. I mean, that's an impressive pressure, I mean, that's because 11 for the right atrial pressure and 22 for the gradient between the SVC and the right atrium. That's 33 millimeters of mercury. That's a lot of pressure.
And occasionally I've certainly seen patients where the JVP is masked because it's so high, and highlights certainly if there's some question over what it might be, to do a right heart cath, as Joe had suggested. In this case too, even though you might be fooled because the IVC is collapsible, but you're really looking for SVC pressure if you're looking for SVC obstruction. And that again points to SVC more than her constriction if she doesn't have extra pressure in her IVC, but she does in her SVC. So radiation-induced SVC fibrosis is rare. There's only a handful, about 4 case reports in the literature. The last one was from a few years back that I had seen published. One of the few was associated with acute thrombosis, so there had been some underlying fibrosis and then some thrombus overlying the fibrosis. So always good to review some of the signs. Although we certainly were looking for pitting edema in her upper extremities, just the feeling of head fullness, which she complained of. The facial swelling was difficult in her because she had significant steroids, and it really just looked like moon faces. It did not look pitting at all. And then she didn't have any pitting edema in her arms, although she had a vague complaint of saying that she felt like she was swollen. Her diagnosis was delayed slightly because she got it on her first outpatient visit, just because we deferred invasive procedures during the time of the hospitalization, given her improvement in symptoms and her wanting to avoid invasive procedures, and she really was ready to go home by the time we saw her in the hospital. But certainly the right heart cath was necessary in this case to make the full diagnosis. And so that's what I had for the first case. I don't know if anyone else has any questions or comments.
Let's see.
This is Lauren.
Go ahead,
Sorry, this is Lauren Baldessari. Sorry, I logged in a bit late, so I might have missed this. But did the patient have a cardiac MRI to look at constriction in the pericardium?
She did not. We did not pursue too aggressive of an evaluation for constriction, just because the treatment itself would have been morbid, and we were looking for minimal ways to try to make her feel better. But that's a great question.
Okay, great. Yeah, I mean, sometimes we'll do like a dedicated protocol with real-time imaging rather than the usual retrospective. And we'll do, like you do on echo, the deep inspiratory motion, but it's really nice because you can see it move with the diaphragm and clearly see the adhesions, and then also clearly see items like thicken. But like you mentioned, obviously, we'll often do that pre-surgical to help the surgeon, with their pre-surgical planning. But I think if that wasn't on the table for her, it might not have been helpful. It could have been helpful to look at the SVC if you wanted to look at, prior to doing the right heart cath, or potentially in lieu of that, to look at the pressures. And you could also measure the gradient with phase contrast imaging as well. So it's just one kind of non-invasive option.
Yeah, that's a great suggestion. And
what happened to her? Sorry. What happened to her sinus node tachycardia? Her sinus tachycardia. What happened to that?
It improved significantly after her SVC obstruction was addressed.
Josh, if you put her arm up in the air, could you measure her central pressure by looking at her veins with her arm up in the air, the arm veins.
Yeah, we did not try that. I've used that before, and that's a great suggestion to do that. She really, I think, fooled us on our initial evaluation in the hospital, and just because she really didn't look overall wet or volume up, and her JVP really did look normal at the time. But certainly it was hidden in a good thing to bring up as far as not missing that.
Yeah, and I think the other thing is, just in terms of the practicality of who is going to do this stenting procedure, I would be curious at other institutions, who do they think that they would contact to potentially intervene on the SVC syndrome? Would you contact surgeon or an interventionalist, as in this case, or an interventional radiologist? What would be the other institutions, referral patterns in that setting?
Yeah, it's clearly localized in. I mean, here at Penn, the IR guy would do this.
Yeah, I think we engaged one of our cowboy interventionalists who is willing to put stents in any part of the body at any time, and other assorted things. So we felt very comfortable that whatever they encountered, that they would be able to come up with a solution. So I mean, I think that's a great advantage to have somebody like that. I don't know if that's routinely available at every place or not, but
so I just want to make one other comment that I know it's been reported. I can't give you the reference, but I've seen a lot of people with acute pericardial disease that after in the retreatment or pre-treatment period, the echo has features of constriction. Right? It always goes away when you treat the underlying cause. So it's, when you see that, it shouldn't be a trigger to call somebody to do a pericardial stripping.
So yeah, I think the downside to pericardial stripping, especially in this lady, was that she already had radiation-induced lung injury as best could be determined, and was quite tenuous, requiring oxygen. And then her whole tumor situation was surrounding the heart in multiple ways. And, so I don't imagine it would have been very pretty if you went in there to try to do some sort of pericardial stripping.
Yeah, fascination.
You would have encountered a lot more than you wished for on that. But then the other piece is that you look at the surgical outcomes of people who go for cardiac stripping, for pericardial window, or I'm sorry, pericardial stripping, and it's a more morbid procedure than any other CT surgery procedure that you would propose. So especially if somebody's had radiation before. So the chance that you're going to meaningfully impact their outcome by doing the pericardial stripping it's just not very feasible.
I think the mortality approach is 100%.
Yeah, the immediate mortality is reported around 20%, but if you look at 3-month survival, it's probably 0.
So you think this was the fibrosis of the SVC, or could it be the mediastinal tumor extrinsically squeezing that? Do we need the MRI to confirm what the pathology is?
Yeah, I would say that the tumor was out of control. So I believe it was extrinsic compression, but I'm not sure you would definitively know that. And I think at this point she has a really big stent. I don't know if we could even do an MRI. I'm not sure. Lauren, can you do an MRI in somebody who has that big a stent?
Well, usually the stents are not material that is ferromagnetic, and so you should be able to do the MRI of the stent. There's certainly no restriction in coronary stents, although initially they thought there was, and then moving any kind of metal through an electronic field can generate some kind of current, but I don't think it's a problem personally.
Okay. Great.
I just have as an oncologist background. By the way, I'm Xu Yang from China, has been doing research in America. So from oncologist point, so the patient's one strange thing is it's very rare to see the patients after radiation to induce such a strong cardiac side effect. So I agree with the authors. It's maybe associated with acute thrombosis. So from that point, I was thinking maybe this patient, I'm not sure if you check his thrombosis, like PT, those data, how the patient, if he has any, have you excluded any other disease, especially for his, vascular disease or genetic problem for thrombosis? So if that's possible, then all the other symptoms seems like can be explained. Because it's hard to explain the patient after he had a regular radiation to induce such strong side effect.
Yeah, I mean Josh can certainly take that one, but I think that the radiation was just a few months ago, and that seems a little early in the time course of radiation-induced fibrosis, or at least on the vasculature. But I certainly cite that as a possibility. But I think that the mediastinal tumor is out of control, and that's probably the reason why we had such an impressive extrinsic compression of the SVC. And then, in terms of anticoagulation, post-procedure, I assume, Josh, didn't they just recommend aspirin and Plavix, or what was the recommendation there?
Yeah, I think she's just on antiplatelet.
Yeah.
As far as whether the etiology was radiation-induced fibrosis, extrinsic compression, or thrombus on top of fibrosis, I honestly don't think we have the information. It's anyone's opinion, with all the caveats that I know Dan just mentioned as far as the time course for the fibrosis. She certainly had a catheter in place for chemotherapy and could have had a thrombus associated with that. As bad as the tumor looks to me on the CT, oncology was actually happy with her response to treatment. And so it wasn't growing, but certainly what is there may have been compressing on the SVC as well.
Super. So, Eric, can you transfer the screen to me? Is that possible?
Yep, we're doing it right now. Hang on just a minute, please, Dan.
And this is Lauren. Sorry, I was muted before, so I couldn't answer your question, but I agree with what Eric said. There shouldn't be any contraindication, after the stent placement, but it would probably, depending upon the material, cause some susceptibility artifacts right in that area. So it wouldn't be good at that point for evaluation of the SVC. You'd be a little bit limited with some of the images, but it would have been fine, to evaluate it before.
So, I think at this point in time, is it important to try to define those things? post procedure? Do we need to try to evaluate whether there's thrombus or, tumor progression, or do you think that an MRI is an important test at this point to evaluate the ongoing results of the procedure? Or what do you think?
Well, I think it's going to be a little bit difficult to visualize within the lumen of the stent. I don't know exactly what type of stent they put in, but there's going to be some limitation in what you can visualize that's within the lumen. Sometimes we can, but it'll probably be pretty limited. It probably would have been more helpful before. If you have a question about stenosis, you could still do the phase contrast imaging to pick up the velocities and the gradients. That would be fine. But the cine imaging and like thrombus imaging will probably be pretty limited within the area of the stent, but it shouldn't cause significant artifact outside the area. So if you still had a question about like the surrounding tumor or constriction in the pericardium, you could still do the MRI for that reason and get some good images.
Super. All right, so can you guys see my screen?
Sir.
So, okay, so our second case is equally as challenging, or perhaps more so, but so we decided that we were going to go with our most emotionally challenging cases, just so that we can share the love with everybody. So this is a lady we just recently saw who's 18 years old, and that in and of itself makes you very upset, who originally presented in August of 2017 to a local hospital with cardiogenic shock, and ultimately was found to have a large pericardial effusion and a right atrial mass. So she was quite sick in the ICU for a while, but ultimately when she was stabilized, she had a percutaneous biopsy of this right atrial mass, which was ultimately angiosarcoma. Now, I still have great respect that they were able to do a percutaneous biopsy in the cath lab, and they actually did this at Children's Hospital since she was 17 at the time. But I don't know if any people out there have experience with doing an intracardiac mass biopsy percutaneously. Is anybody doing that kind of stuff? No
I'm
comments.
surprised to hear that, because we the ones I've been involved with have always been with a regular biopsy, through the veins.
Well, no, I mean, I think, if you're going to do a cardiac biopsy, that's one thing, just looking for rejection or amyloid or something like that. You just do the standard biopsy. But an actual mass in the right atrium, how do you biopsy that? Physically,
Well, ultrasound.
Yeah, well, I guess.
Use with
But
ultrasound.
I don't know how many. I mean, I think it's really interesting that you don't seem shocked by it at all. I think that that would so not have happened at Vanderbilt or Houston or wherever else I was.
Not here. It wouldn't happen here.
So I think I'm just giving their due dibs, that they were able to do it. It's great. But anyway, to carry on the story, she also had bilateral pulmonary nodules at the time that were considered to be metastatic disease. So this is in August of 2017. So then the treatment included radiation beam to her heart. External beam radiation to her heart, and then she had paclitaxel for several cycles. And there appeared to be some improvement in the pulmonary disease. No real change in her cardiac status. And then she was placed on dual checkpoint inhibitors with ipilimumab and nivolumab, starting in September and all the way through to February of this year. She did have some evidence of worsening of pulmonary disease, and that was mainly based on not the nodules, but the fact that she had pneumonitis / pneumonia that required hospitalization in February. So the cardiac mass was felt to be stable, although they, were having a hard time seeing a big change in disease. And then in February of this year, she was started on adriamycin and olaratumab. How do you pronounce that? Olaratumab, which she got several cycles of that and was considered to have stable disease until April of 2018 when she had restaging. And then we were asked to see her just recently, and she was anticipating cycle 7 of the adriamycin regimen. So here's some particulars of her echoes. The first one in August of 2017 showed normal function. She had a 5.3 centimeter right atrial mass. She had a repeat echo about a month later that showed perhaps mild LV dysfunction at EF of 52%, and the mass had perhaps been reduced slightly. And then in September, again, a repeat EF was around 50%. In January, she had what was considered borderline LV function. There wasn't a specific EF measurement, but presumably it was around 50%. And the mass appeared to be a little smaller. There may have been some degree of SVC obstruction with a very small gradient detected across the SVC.
That's fine.
Baseline strain from any of those echoes, baseline strain?
Yeah, so we don't have baseline strain in most of them. I do have a slide coming up comparing these two echoes, the one in May and the one in July, which we just did. I have strain on both of those, so I'll show that to you. But so in May of 2018, her EF was 55, and then in July 2nd, her EF was 47, according to the echo, with a GLS of -16, and the mass seemed to be a little smaller. So we were consulted at this point because of a possible significant drop in EF, and here's some of the details. The first adriamycin cycle was in February, and she reportedly had an EF greater than 50% in January. And then she got a cycle on June 20th of anthracycline-based treatment, and the EF shortly thereafter was 47 with the strain of -17, GLS of -17. Other important things when talking to her, I mean, she was generally fatigued, which is not surprising. She was getting ongoing chemotherapy, but she also reported dizziness when standing, especially over the past few weeks. And she is a swimmer, plans to go on a vacation, and has all these plans, and included doing a 2-day orientation for college in the next few weeks. So she just did that. And then her physical exam is noted here. Blood pressure was 80/60. Heart rate was about 120. Her respirations were 18. She was, O2 sat was fine. Other than the tachycardia and no evidence of JVD, she really, her cardiac exam was her exam was otherwise unremarkable. Her medications are listed there, and the one of note is the lisinopril of 5 milligrams a day. That had been placed a few months ago, or about a month and a half ago, because of the borderline LV dysfunction. and they were trying to get her to tolerate lisinopril. And then over the past few weeks, she'd been having the problems with feeling dizzy whenever she stood up. The rest of her labs were not highly abnormal. Her platelet count was a little reduced from the recent chemotherapy. Here's her echo from May. Do you guys see that?
Yep.
Yeah, we can see it in place.
Good. So this is just one view. You see the overall structure of her heart is pretty normal, not particularly dilated. Overall function looked pretty normal back in May. And then if you look in the right atrium, you see the mass coming in and out of view. The echo images from the July echo are shown here. Here's a couple of them. Peristernal long axis up on the left and the four-chamber down on the bottom. I'll show you side-by-side images in a second, but if you just sort of mentally compare the four-chamber to the one done in May, you can't really say that the right atrial size mass is any different. Perhaps the septum may be a bit fuller, but it could easily just be shadowing from the mitral valve or other valvular structures. And then here's her comparing a short axis view. The one on the top is from May, and the one on the bottom is from July. So, Eric, what do you think about those?
Oh, usually I like to look at the distribution of the points, the data points, when you get the strain, and then push the button to make it into the polar map pattern. So I don't see that, but the polar map pattern certainly circumferentially almost is abnormal on those polar maps patterns. Of course, strain is a very difficult procedure to do, whether it's on a 4D sort of image where you get them all in one's heartbeat, or whether you do it on 2D images and process it through multiple heart rates. But it's very difficult to do, and it took us 4 years to really perfect strain. And so I'm not exactly sure how much you can count on it unless you've had a lot of experience with this particular machine and technician. And if you don't have a baseline, it makes it even more difficult. So that's,
do you see the short axis loops? Are they playing?
Yes, the short axis loops are playing, and they look a little bit inhibited in terms of contractility. It's playing at the level of the papillary muscles almost, mitral valve papillary muscles, and it looks like globally it's somewhat reduced and matches sort of the pattern you see on the polar maps.
And do you think that there's any difference between May and July in terms of LV function, at least visually?
That's a tough one. But it looks a little, doesn't look as good as it did, but it's a tough one because we're talking basically percentage points of 3. And probably the standard deviation is plus or minus 7. And so that's kind of tough.
Yeah, so the one up on the top, the EF was red. The particular number that was quoted was 55. And the one on the bottom, the number was 47. So I don't know if you see an 8% difference between the two, if you see that, or
that's tough. I guess what I do see is a little decrease in the superior short axis view around 12 o'clock, 11 o'clock, 10 o'clock, around there. That looks a little different from the other image, and maybe that's what's producing that, and I don't know why that looks different, but it's certainly doesn't seem to have as much motion in terms if you were to drop a radius from each one of those to a central point, that would there would be decreased radial shortening up there.
Yeah, and so then there's the strain images. The one on the top is from May, and the one on the bottom is from July. And you already commented a bit about that. Do you think they're intrinsically different or not?
It's tough not having had a baseline strain before you got started here, and not knowing the tech, and not knowing the machine, and not knowing how you did it, if you did it on a 4D image, and so it was one heartbeat, or if you did it on several heartbeats. And so it's the strain is very, very difficult. It took us 4 years to really perfect strain. So comments all have to be deferred to your knowledge of the tech and the equipment and what's come before this.
Yeah, and so the GLS average was 15.4 in May and 16.0 in July. So at least just that data in and of itself obviously is not any different. And so then, kind of makes you wonder, the EF was 8 points different according to the measurements, and GLS is unchanged. Was there any substantial change or not? I'd certainly struggle with that one.
Yeah, me too. And it's that superior part of the short axis where you get 11 o'clock, 12 o'clock, 1 o'clock. Around there looks like it's not moving as well, and I don't know why. And so that makes me wonder about the image acquisition or something. And so I'm not going to. There shouldn't be regional wall motion abnormality, and so to have that region different makes me wonder about something about the data.
Okay, thank you. So then just to fill out some other details, in April of 2018, the CT of her chest showed the mass circumferentially narrows the superior cavo-atrial junction. So it's like all around the right atrium, and but did not appear to cause any kind of complete occlusion. The mass does appear to extend into the right ventricle, does not apparently invade the intra-atrial septum. Again, this is by CT, and this is in April. The right ventricle, left ventricle, and left atrium are apparently normal. CT from July 9th, so just 2 days ago or 3 days ago, shows a 4.3 centimeter mass along the anterior mediastinum, and then possibly the pulmonary nodules have increased from 1.7 by 1.2 to now 2.7 by 2.4.
I'd like to comment on the measurements that we make, and we're dealing with three-dimensional images, and we continue to make two-dimensional measurements, and there is very sophisticated software that everybody has on their software for analysis of CT scans that will give you three-dimensional measurements and volume measurements of any nodule or lesion that you want to measure. And so to continue to measure 2D is kind of stupid.
Yeah, well, I wouldn't argue at that point, but that's what the report says, so I kind of went with it. But and then she also got an MRI because we were concerned about whether there was any true cardiac dysfunction. That was one thing, and then the second is, could we get a better idea about the extent of this mass in the right atrium? I mean, you certainly can see it by the echo. So the MRI showed an EF of 51% with basically a normal cardiac index. She did have a large mass in the right atrium that was adjacent to the pericardium, invading the superior vena cava just above the cavo-atrial junction. And then there appeared to be mild narrowing of this junction. There did appear to be increased size of the pulmonary metastatic disease, and the MRI had some 2D measurements as well, as you mentioned. Here's her image. I don't know. Can you guys see that? I don't know. Does everybody see the screen?
We see it well.
Yeah.
Yeah. Okay. So the LV is here, obviously the RV is here, the tricuspid valve, the right atrium. You see an obvious mass, and then you also see that it is sort of abutting and part of the right atrial wall, right where the SVC is. So pretty substantial mass that certainly does not appear to be getting smaller. And then the really bothersome thing is that she has a sizable pleural base met in her lungs, which seems to be bigger. So, you know, what do we do with all this? This is really tough. And, you know, in one way, Ron had mentioned before about Avabradine. I think we may want to go to that because, again, her blood pressure was 80/40, and she was on lisinopril and having hypotension when she stood up. So the idea that she could tolerate beta blockers seems pretty unlikely. But that's what we chose to try, is a very low dose of carvedilol to suppress her heart rate a bit. And then we wanted to check standard cardiac biomarkers, which have not been checked yet. And, you know, see if we can eke her along as she undergoes further anthracycline-based treatment. I really didn't feel that there was any true evidence of a change in LV function. But, you know, at least based on the echo reports, it looked like she may be having some evidence of cardiac toxicity, but, you know, it's not clear. So does anybody have any other thoughts on that?
What if I got an echo and I saw him a year ago?
Can I have a question?
Sure.
Sebastian Schmidt from Poland. Congratulations on you. Excellent case. I'm impressed. I have one question. Did you consider to use dextrazoxane or liposomal doxorubicin for this patient?
You know, that's a great point, and I think at this time I would definitely do that. I think that's a great point because you know, unfortunately she does not have any real good options, and she needs anthracycline, and I think that it would be really important to give her desoxane so that she can tolerate more anthracycline, basically. I think that's an excellent point.
And I also wonder if that's possible to do a catheter to take the tumor out instead of doing the whole body chemotherapy.
Yeah, I think that if I had a fleeting thought about that in that if she had, you know, presumed pulmonary metastasis, but they either were sort of equivocal or they went away with treatment, then you might be able to make an argument to do, you know, an auto transplantation, which is a procedure done primarily in Methodist in Houston, where they take the heart out and they cut out the tumor and then they reconstruct the structures that they have to cut out and then they put the heart back in. They haven't done that frequently, but they have done it in 10 to 15 cases that I'm aware of as a possible treatment for sarcoma, angiosarcoma of the heart. So, I mean, that would have been a possibility, except for that metastatic disease, that pleural-based mass in her lung probably means the cancer's well beyond the heart structures, and doing a major surgery like that is probably not going to benefit her.
You know, when we have a liver cancer for the patients, we can do is put a cath in the cancer area and shooting the chemotherapy medication, just put it in the tumor area or tumor inside, and that can kill the tumor because the chemotherapy medication is very high concentration in that area. So I was wondering, instead of taking the heart out, like a big surgery, is that possible to do? Just put in like a catheter or something into the sarcoma tumor, and put in the medications, avoid all the side effects, and this is also increasing the dose of the chemo around the cancer area.
Yeah, no, again, that's an excellent suggestion. I don't think it's possible in her because the cancer is not localized to only some spot in the right atrium. But yeah, I think you definitely have to think about all your tools and how you're going to approach these kind of very resistant cancers. So I think that's an excellent suggestion. I don't know if it fits for her, but
Dan, have you done a PET scan? Do you know if those pulmonary tumors or masses are pulmonary infarctions from embolization? Maybe they got some pulmonary emboli that occurred from clots on top of the tumor that embolized distally and caused pulmonary infarctions, as opposed to being a tumor met that sat there and grew. Can you distinguish that with a PET scan so we can find out
that's
if you...
Also a good suggestion. I don't believe they've done a PET scan.
We've had patients with tumor masses, that right atrial myxomas, and we've had some that get clot on top of their mass, and then it embolizes, and then they get pulmonary infarct. And then you say, what are these? Are these tumors? And then we try to distinguish that with a PET scan to see if there's some activity there. If there's no activity there, then we presume it's a pulmonary infarct, and it's kind of wedge-shaped.
Yeah, I mean, like I said, I think it's an excellent idea, and I will talk to the oncologist about that today, see if they were planning on doing a PET scan.
That would change the ball game because we'd only have one tumor.
Yeah, I mean, potentially opening up some of these other treatment options we've talked about.
And then I also have a question. Since we have this cardio-oncology program for so long, but I just curious, is there any regulation for like doxil or angiomycin, this kind of very strong cardiac side effect medication to be treated in, especially for the young kids, only 17 years old? You know, if they have been, this cancer is a little bit different, but because this is hard to treat, but for some cancer will be easier. What is the regulation for the azithromycin or this kind of medication used in young kids?
Yeah, I think that, you know, I don't ever determine whether you know, an oncologist wants to use anthracycline or some other drug. I think we just try to, you know, manage their cardiac issues accordingly. So, you know, they have to ultimately decide what drugs they think are going to be effective. And I know in the cases of sarcoma that they frequently believe that anthracycline are really the core therapy. But you know, I don't. Other than that, I usually just wait and see what they're going to decide about their treatment.
Yeah, we've seen some demonstrations, experimental laboratories using nanotechnology and basically some nano encapsulated tumor necrotic cells or our tissue or our drug that can then, when it gets in to the cell, then it will kill only the tumor cells because it won't go anywhere else because of the antibody that you use to tag onto the surface of the cell.
Yeah, I think that if there was a way of thinking about that kind of treatment in her case, I would be all for it. Believe me, because you know she is. Yes, it's really upsetting to see an 18-year-old who wants to go to college in a few weeks, you know, dealing with these kind of issues. All right.
Just
Thank you guys so much.
terrific
Thanks, Dan.
cases, Dan. It's going to be very hard to try to equal that in August, and so you've done a great job, and I appreciate the work Josh has done as well. And you guys are doing a terrific job there at the University of Washington U. Very impressed with your technology.
I have to,
Got all
I
the
have to thank
imaging. I like the
Holly
screen actual.
Weaverhand.
I think you've improved a lot from moving from Vanderbilt to Washington U. You've got a much better imaging stuff.
That's true. But I also want to thank Holly Weaverhand for being the glue that keeps us all together. So it's key.
Yeah, watched the special on it.
All right. Thank you guys.
Thanks, everyone.
Thank you so much.
We want to say goodbye to Ahmed for coming today, and Brett and Calvert, Holly, Jody, Joseph, Carver, Kathleen, Lauren, of course. We're glad to hear from you. Marcelo, thank you. Nadine, Henning, Ronald Crum, Sebastian, it's good to talk to you again. And Zhu Yang Ping, thank you very much, everybody, for attending today. We appreciate it. We will record this, and this will be posted right now at Eric E. Harrison, MD, Vimeo, and with public access. And in the future, we'll have it linked to ICOS website. So thank you so much. We appreciate it. Bye-bye.
Thanks, Bye.
Thanks a lot. Bye-bye.
One of my patients has an S4, and I was just wondering, like, what that could mean, why she would have that.
You can hear them again.